Hello, I am Dr. Keith Burke. I'm a professor of behavioral sciences in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a state-funded vocational or job training program for students who desire to be certified alcohol and drug counselors. The AODS program covers all of the coursework necessary for the student to sit for the state certification exam, and that coursework is also college level coursework, so it can apply towards further educational pursuits such as associate's degrees, bachelor's degrees, and some of the preparatory courses sometimes needed for mental health graduate level degrees. All right, today I am going to talk about identifying mental health symptoms in substance use treatment. All right, this is a fairly long lecture about identifying mental health symptoms for clients who have co-occurring disorders, although it in no way reflects the complexity of mental illness, and it should be considered a basic survey of some of the major mental health symptoms that alcohol and drug counselors will come into contact with when they're working in substance use treatment facilities. So it's important to note at the outset that everyone has mental health symptoms at different times in their lives. Every person is going to experience some degree of depression at some point. Every person will experience some degree of anxiety at one point. And sometimes even more significant mental health symptoms may happen at least once to many people, and many people have a few mental health symptoms that persist throughout the course of their life. The key here, as my PowerPoint is frozen, the key here, there we go. The key here is that for a mental health condition to rise to the level of a DSM-5 diagnosis, there must be a characteristic cluster of symptoms. Cluster of symptoms meaning that they're related symptoms that are consistent with how that disorder is defined. In a different lecture, I talk about substance use disorder diagnosis. And in order to diagnose a substance use disorder, the alcohol and drug counselor will use the DSM-5, typically, the American Psychiatric Association's Diagnostic Statistical Manual of Mental Disorders. And they will use the 11 criteria listed in the DSM-5 to determine if somebody has or does not have a substance use disorder. That is the same exact process that happens with diagnosing mental health disorders. A mental health clinician will use the DSM-5 or another diagnostic system to determine what are the actual criteria associated with this diagnosis, and does my client meet those criteria. So having a mental health diagnosis is different from having mental health symptoms, in that the diagnosis means that the criteria associated with the diagnosis have been validated and identified. So the other important part about mental health symptoms in order to reach to the level of a mental health disorder is that the symptoms must cause, quote, clinically significant distress or impairment in social, occupational, or other important areas of functioning. That quotation is out of the DSM-5. So what it means is that the symptoms can't just be there, but they're creating a serious problem in life functioning. It's blocking a person's ability to do what they need to do. So if you have symptoms of depression because you recently experienced some life event, you had to put your dog down after 16 years of a very long and loving relationship, and it's cloudy and rainy today, and you've been working too hard without having taken a break, it would be totally normal for you to have depressive symptoms. But to rise to clinically significant distress or impairment, if you have those depressed symptoms and you're still going to work, maybe not with as much enthusiasm, but you're getting up and you're going to work, you're engaging with your family and friends and talking about how sad you are, about recently having lost your dog, you're eating, you're sleeping, you're showering, then the depression symptoms are not causing clinically significant distress. But if the depression symptoms are such that you climb into bed and you don't get out of bed for 72 hours, you don't eat, you don't shower, you don't call in sick to work, you can't even rise to making that phone call, that would be clinically significant distress that is impairing with your occupational activities and daily living. So anytime we are assessing severity of mental health symptoms and trying to determine if these mental health symptoms warrant some kind of a further referral, we are going to want to assess for how clinically significant is the distress or the impairment. Now, substance use counselors, at least in the state of California, do not need to diagnose or know all the rules and specifiers for mental health disorders. Substance use counselors do need to know how to diagnose a substance use disorder. So they are expected to be familiar with the diagnostic criteria for substance use disorders, the specifiers for diagnosing substance use disorders, but not any of the other mental health conditions. So substance use counselors do need to recognize the major symptoms that are associated with mental health conditions and be able to make an informed decision whether these are typical post-acute withdrawal syndrome symptoms or if they signify a need for a mental health referral, meaning that the alcohol and drug counselor has to be able to see my client has experienced something that is consistent with mental health, and then be able to do enough of a screening and assessing with the client to determine, yeah, this is actually a mental health condition. This is not just typical depression associated with post-acute withdrawal symptoms. I'm going to talk more about that in just a second. So when an alcohol and drug counselor observes symptoms that seem consistent with a mental health condition, then they need to screen. They need to ask questions appropriate to determine if the client has a previous diagnosis, the nature of the symptoms, what kind of treatment they've had in the past, all of which I discussed in a different lecture on screening and assessing for mental health and substance use treatment. So in that screening process, the alcohol and drug counselor will gather information. They will document the symptoms they're observing. They're going to ask the appropriate questions. And then you should be consulting with a mental health professional or referring to a mental health professional, hopefully on your own multidisciplinary team. Most substance use treatment programs nowadays have mental health clinicians employed by the treatment facility. They may or may not be there every day, but they are there around and treating the people. Many have on-site psychiatrists. So these are the people that you'd want to be talking with when you observe what appears to you to be a mental health condition. Now, before we continue, let's take a little side note here on post-acute withdrawal syndrome, just to review what PAWS, post-acute withdrawal syndrome, is. So acute withdrawal symptoms that are associated with whatever the drug is that's leaving a person's system, those acute withdrawal symptoms typically end between 72 hours and 2 weeks. Each drug of abuse has its own characteristic withdrawal syndrome, which I am not going to be going over in this lecture. But all of them are associated with an acute period, basically as the drug is exiting the person's body and not being replenished, the body goes through an acute withdrawal. However, often the process of alcohol or drug withdrawal can lead to prolonged withdrawal symptoms that are post or after the acute withdrawal. And this phenomenon is referred to as post-acute withdrawal syndrome. Essentially, post-acute withdrawal syndrome is after the drug has left the person's body and has not been replenished. There are still symptoms that seem like they're withdrawal, even though they're not necessarily related to the removal of the toxic substance that the person was using. So PAWS is occurring as the brain's neurotransmitters are recalibrating or healing after active addiction. Now, this is also not something I'm going to talk about at length in this particular lecture. We have a course in the Alcohol and Other Drug Studies program at San Diego City College on pharmacology of the drugs of abuse, in which our very talented pharmacist and program director, Wendy Wheel, goes through all the different withdrawal syndromes and the different neurotransmitters that are implicated in both addiction and withdrawal. But suffice it to say that post-acute withdrawal is happening because the brain, having been changed by the consistent and addictive use of a substance, has to now change back or recalibrate or heal. And typically this process is going to create associated symptoms that are then related to the pause symptoms that people are experiencing. So pause symptoms can last for 6 to 18 months, and then they typically will dissipate or go away without the need for additional or supplemental treatment. Meaning that while the person's experiencing these, they may be distressing, but unlike a typical mental health condition where an intervention is called for, some kind of psychotherapy or psychotropic medication in order to treat it, pause symptoms will go away as part of the normal recovery process, basically as the brain gets itself healed back enough to return to something resembling a baseline or where it was prior to developing an addiction. Now, it is estimated that 90% of people recovering from opioid use disorder and 75% of people recovering from alcohol use disorder have pause symptoms. Alcohol is the most common drug of abuse that we see in substance use disorder treatment facilities, and opioid use disorder is also a very significant segment of the population, at least now in the 2020s. Like all drugs, comes and goes. For a period of time in the 1980s, cocaine was a really big drug. Methamphetamine took its turn. Opioids have taken their turn. Alcohol remains consistent. But regardless, this is a huge percentage of people. Essentially, it's safe to say that most people will have post-acute withdrawal syndrome symptoms as they are withdrawing and in treatment facilities. Now, pause symptoms are largely psychological in their manifestation. They appear very similar to those found in mental health mood disorders, most commonly depression and anxiety disorders. This is underlined because it's an important thing for the alcohol and drug counselor to note that people may be manifesting what looks like mental health symptoms that are largely related to the fact that they're going through post-acute withdrawal syndrome. We'll talk more about what to do about that. Now, some of the most common pause symptoms include depressed mood, anxious mood, impaired ability to focus, and difficulty with cognitive tasks, which can be very frustrating for the person when they're in treatment. Most treatment programs have some kind of assignments or activities or packets. At the very least, hopefully they have the clients doing a relapse prevention plan. And that's a cognitive activity. That's requiring putting thinking into this, doing a self-analysis, triggers and warning signs, developing plans, writing it down in a planned format. And so many people who have pause, they're having a hard time focusing. They're having difficulty with this. Their brain feels foggy and slow, which can be very frustrating. Mood swings up and down is very common. Irritability, which sometimes looks like the hypomania that's associated with bipolar disorder. More about that later in this lecture. So it looks like that kind of irritability, but it's just associated with pause. Feelings of panic, similar to panic disorder, increased sensitivity to stress, having apathy or pessimism or lack of initiative, meaning feeling like you don't want to do anything, it's hard to get started on things, typical of depression. Fatigue and disturbances in sleep patterns, sleeping too little or sleeping too much, developing obsessive compulsive types of behaviors. We'll talk more about that. Issues with fine motor coordination. Things like holding a pencil, throwing a baseball, things like that. That's fine motor coordination, often challenges with that with pause, and difficulty managing social relationships. That may seem kind of an odd one to put in there, but to really manage social relationships, romantic relationships, family relationships, any kind of social relationship takes a certain level of awareness and focus and empathy and thoughtfulness, all of which is challenging. And so we often see challenges with people while they're in pause, having difficulties just doing basic things like being social with other people. Now, although pause symptoms will tend to resolve without the need for mental health treatment, pause can be really challenging to distinguish from a latent or hidden mental health disorder that's independent of the substance use disorder, especially if it's lasting for up to 6 to 18 months. So most treatment facilities, you're not even going to have the client for 6 months. So it's not like you can wait around for 6 to 18 months to see if they resolve themselves. So if you see symptoms that may be well related to post-acute withdrawal syndrome, but may also be related to a mental health condition, it's usually best to refer to a mental health clinician or a psychiatrist for an evaluation. Clients are often going to benefit from mental health treatment for pause in the short term. Practicing emotional regulation techniques, developing good sleep hygiene habits, being prescribed a mild antidepressant or anti-anxiety medication while they're in treatment. These are all things that don't necessarily need to be done for lifetime treatment of a mental health condition, but it can be really helpful in those first months as someone's going through pause. All right, so what I'm going to do now is we're going to go through this lecture and talk about some of the major mental health disorders that you're going to see in substance use treatment. Again, this is a basic survey. This is not getting into super great detail with any one of the disorders, but just talking a bit about the symptoms that are associated with the disorders, enough that the alcohol and drug counselor should be able to recognize them when they see them. So the first one we're going to start with is depressive disorders or depression. So there are many variations of depression and the depressive disorders listed in the DSM-5, but the common feature is the presence of sad, empty, hopeless feelings that include a diminished interest or a diminished pleasure in almost all activities. That last part there, the inclusion of diminished interest or pleasure, is related to the clinically significant impairment that I was talking about earlier. So a kind of a chronic lack of energy and lack of interest in things that used to be interesting to me, doing things that used to be pleasurable and not getting any pleasure out of them. That's a bit more than a depressed mood because you had to put down your loving companion dog. This is usually significant and suggestive of a deeper depressive disorder. Now, depression also includes diminished cognitive or thinking capacities that are significantly affecting their ability to function in day-to-day life, including the inability to concentrate or think clearly. So here's an example, one of many, of where pause and mental health conditions can overlap. So if a person is showing frustration with some of the tasks, the written tasks that they have to do in treatment, they're telling you they're having a hard time functioning, that could be depression and it could be pause. And so when in doubt, we're still going to engage with the mental health clinicians and treat that ourselves as well with the skill set that you have as an alcohol and drug counselor. Now, the suicide risk with depression is significant, although it's not the highest risk of completing suicide. Many times people who have depression have this chronic suicidal ideation, chronic thoughts about suicide, or kind of vague, unformed wishes that they weren't here or they wouldn't get up any longer, but not having a plan or a means to carry out that plan. That's very common with depressive disorders, although still needs to be assessed and addressed, which I talk about in a different lecture on suicide risk and suicide screening and assessment. Depression also often includes sleep disturbances, which may be either excessive fatigue in sleep or insomnia. People who are depressed often don't get out of bed, stay in bed for long periods of time, but in spite of the fact they're not getting restful sleep, they may be tossing and turning, waking up constantly throughout the day and the evening. And some people with depression can also have either significant weight loss or significant weight gain. Now, evidence-based treatment for depression includes medication management. It responds very well to antidepressant medications, using motivational interviewing to increase motivation, solution-focused counseling, cognitive behavioral therapy. CBT really it came of age in the treatment for depression, and there's lots of evidence that CBT can be really helpful in lessening depressive symptoms. Emotional regulation techniques, which an alcohol and drug counselor can easily do with a client who's depressed. Basically, you're just teaching the client how to regulate their emotions, how to speed themselves up, develop some energy. One of the most important things for people who have depressive disorders is that they move, literally just get up and move, because sitting, lying, laying in bed tends to perpetuate the depressive symptoms. And the act of moving, even if it's just simply going for a walk around the block, typically will lower depressive symptoms. So that's a form of emotional regulation. Psychoeducation about depression and support groups. All right, the other common disorder that we see all the time in substance use treatment, in addition to depression, is anxiety. So anxiety disorders are varied. There's many different variations of the anxiety disorders, but they all share features of excessive fear, distress, worry, and anxiety with related behavioral disturbances, meaning that all of the anxiety disorders have some kind of anxiety, worry, concern, fear that's causing a change in behavior. So studying for a final exam is going to create anxiety in most people. And driving to the college while you're on your way to take the final exam is also probably going to have some anxiety. And certainly sitting down in the classroom as the professor is handing out the final exam will make most people feel a little bit of anxiety. But in those examples, there isn't a behavioral disturbance. So developing anxiety because of the final exam and suddenly feeling so paralyzed with anxiety that you don't get in the car, you don't drive to school, in spite of the fact that now you're really freaking out that if you don't show up for the final exam, then you're definitely going to fail the final exam, but you can't help it. You're feeling so agitated that you're unable to actually drive to college. So that would be a behavioral disturbance because of the symptoms of anxiety. Now, it's also important to note the distinction between fear and anxiety. So these are definitions out of the DSM-5. So fear is defined as the emotional response to a real or perceived threat, which is appropriate. So if I'm walking down the street and a dog is coming towards me and it's a big dog and it's growling and it's drooling and it's got a crazy look in its eyes and it looks like it's about to jump at me, well, I'm going to feel fear. That's totally appropriate for me to feel fear in that situation. And in that case, the related behavioral disturbance is that I'm probably going to run or do something because of that feeling of fear. Whereas anxiety is the anticipation of a future threat. So it's not responding with fear based on an actual threat. It's the mind anticipating that there might be some problem, right, that's going to happen. Sometimes referred to as the what ifs. And so there's a little cute cartoon there. What if I can't do this? What if everyone hates me? What if I faint? Right. So in this case, there isn't something right in front of the little character. I have no idea what that is in that cartoon. Like a pencil head or something. I'm not sure. But anyway, here, it's the mind that's creating the anxiety, the what ifs and oh my gosh, and anticipating some kind of a problem. Now, the anxiety disorders all share a, quote, heightened autonomic arousal or a high sympathetic nervous system. So basically, what a heightened autonomic arousal means is that the body is sped up. The heart is beating fast, the breathing is shallow, and some of these other symptoms, feeling restless or on edge, becoming easily fatigued, having difficulty concentrating, feeling irritable, muscle tension, sleep disturbance. It's like the whole body's just revved up. So all the anxiety disorders have this high sympathetic, heightened autonomic arousal. Now, anxiety and depression both involve impaired concentration and memory, irritability, fatigue, insomnia, and a sense of hopelessness, as does pause to make it even more complicated. There are some distinctions, though, when trying to determine, is this depression or is this anxiety that my client is experiencing? So having apprehension, the what ifs, showing tension in the body, trembling, excessive worry, nightmares, these are all more anxiety related. Whereas the depressed, slowed down mood. Anhedonia is the inability to feel pleasure about anything. Loss in interest in usual activities, suicidal ideation, decreased libido, these are all typically more associated with depression symptoms. So the evidence-based treatment for anxiety includes medication management, emotional regulation, again, deep breathing techniques are very effective for anxiety, and it's something that any alcohol and drug counselor can do with their clients. Motivational interviewing, solution-focused counseling, cognitive behavioral therapy, psychoeducation, support groups, all that actually is the same thing that's used for the treatment of depression. And there's some interesting research into biofeedback, which is essentially a variation of the client understanding how their body reacts to certain stimuli and then using that in order to change the bodily response. Has shown success with anxiety disorders. All right, so the bipolar and bipolar related disorders. So bipolar means that the mood instability fluctuates between depression and not just anxiety, but mania or hypomania, which is a bit different. So it's kind of a combination between depression and anxiety, where the person's moving between those two poles. So this is an emotional regulation chart where you can see the middle zone there, the comfort zone, is where somebody is feeling calm, balanced, organized, they have clear thinking. Whereas down low in the gray zone, the person's feeling depression, terror, shame, dissociation, SI, it's a low. And the red zone is anger, rage, anxiety, panic, mania in fight or flight status, that's high. So the red kind of represents high sympathetic nervous system, and the blue represents a low or parasympathetic nervous system. So the problem for people with bipolar disorders is that they're not spending very much time in that middle zone, in that calm, balanced, and organized zone. They're flipping between the two poles. Now, the move between depression and anxiety can be extremely rapid, meaning it's happening multiple times in a day. Somebody is in a manic, energized state, and then bam, they're almost immediately feeling incredibly depressed, and they just crawl between the sheets of the bed and they don't get up for the next 72 hours. Or it can be slower. Sometimes the cycle can go weeks. Somebody will go many weeks in kind of a high, energized, mildly anxious state, and then it slowly moves down into a depressed state that lasts for multiple weeks too. Now, notable about bipolar, and something for alcohol and drug counselors to be very mindful about, the suicide risk is very high with bipolar disorders, and the DSM-5 cites research estimating that bipolar disorder accounts for nearly 25%, or 1 out of every 4 completed suicides. So a completed suicide means that the person's carried through with it. The hypothesis behind this is that people who are depressed often feel suicidal ideation, but the fact that depression sucks so much energy out of the person, it's hard to have the initiative or the motivation to actually carry through with it. People who have anxiety disorders don't typically have the same level of suicidal ideation, but they're all sped up in their nervous system. Pardon me. Whereas with bipolar disorders, the person, when in the depressed state, may develop the suicidal ideation, but then as the nervous system moves up into a more energized, hypomanic, or anxious state, suddenly they have the energy to actually carry through it. So bipolar disorder and alcohol, it's not on the PowerPoint, but worth talking about. People who have bipolar disorder and alcohol use disorders, the combination of those two things together have the highest risk for completed suicides. So something for alcohol and drug counselors to be mindful of when somebody enters substance use treatment having both of those diagnoses. Now, mania symptoms. Mania is interesting and distinct from anxiety. So when somebody is in a manic state, they are definitely sped up, meaning that the nervous system is really high energy. And it often is, in mania, is also characteristic of a euphoric state, feeling like more than good, feeling really good, like everything's great and awesome and expansive. But it has this level of instability and irritability. Often somebody who's in a manic state, they're talking really fast and they're really like into lots of things and they're talking about things and they're excited about things, but there's no focus, there's no lasting power. And then they'll move really quickly into a state of irritability. I don't know, why are you asking me about that? Why can't you just be excited for me? A sense of inflated self-esteem. They're typically not sleeping. There's these racing thoughts, and often moves into psychotic symptoms. They're hearing things, seeing things that other people aren't seeing and hearing. And then mania inevitably leads to a big depressive crash. There's a movie, sometimes, I don't know if they still do it in the AODS program at San Diego City College, but there's a movie called Mr. Jones that's okay as a movie, and sort of talks about some ethical issues between a psychiatrist and a patient. But Richard Gere stars as the patient, and he gives probably the best depiction, I think, of any Hollywood type movie of somebody in a manic state. It's worth watching and looking into if you haven't seen it already. So a manic state is kind of the typical characteristic symptoms that I was just talking about, whereas a hypomanic state doesn't quite reach the level of mania. So hypo is below, hyper means above. So a hypomanic state means you're not quite in a manic state, but it's typically still associated with not sleeping very much or very well, racing thoughts, irritability. As I said, there's multiple variations of the bipolar disorders with their various levels of severity. But hypomania is more common than outright mania. When you meet somebody who's in a manic state, you're going to know they're in a manic state. Whereas there's many people in substance use treatment who may have bipolar 2 or a diagnosis like that don't quite meet that level of manic psychotic symptoms, but yet are showing this kind of increased activity and agitation and irritability. Irritability is really often associated with the hypomanic state. And pause, as talked about earlier. But the thing about bipolar is that what goes up inevitably comes down. So when somebody's in a manic or a hypomanic state, they do not stay in that state forever, and inevitably it leads to a depressive crash, a clinically significant depressive crash. So evidence-based treatment for bipolar disorder, the first one is medication management. There's a lot of evidence, and at this point, there's been a lot of development and ingenuity in some of the bipolar medications. It used to be like lithium in the 1970s was really the only thing that was working, whereas now psychiatrists have a whole range of medications that they can use. And what the medications do is they dampen the severity of the swings. So the person doesn't get quite so high and agitated and anxious and quite so low and severely depressed and suicidal. They still may have symptoms of anxiety and depression, but it keeps it less severe. Dialectical behavioral therapy, or DBT, which is a type of CBT that's used with more of a focus on emotions, has been very effective, especially the emotional regulation techniques. Motivational interviewing, solution-focused counseling, psychoeducation about the symptoms, cognitive behavioral therapy again, electroconvulsive therapies, or ECT therapies, shocking of the brain. This was a typical and common way of treating bipolar disorder, which used to be called manic depressive disorder, I should mention. I think it was in the 1980s, they changed it to bipolar disorder, but using shock therapies works to keep people from getting into those extreme levels of mania and depression. It had gone away for a while, and there has been a renewed interest in using ECT with a bit better focus. And transcranial magnetic stimulation, similar to ECT, but what you're doing here is using magnets. And there's some interesting research on how magnets can affect the nervous system and some of the severe swings. All right, obsessive compulsive and the related disorders. Obsessive compulsive disorders is one of those things that many people say, oh my God, I'm so OCD. Oh my God, I have obsessive compulsive disorders. And so let's get this out of the way first. True obsessive compulsive disorders, the true mental health disorder of OCD, is characterized by the presence of recurrent obsessions and compulsions, so not just once, happening all the time. But I have underlined that the recurrent obsessions or compulsions are time-consuming and cause clinically significant distress or impaired functioning. So again, if somebody is feeling like they're very detail-oriented and they're like, oh my God, I'm so OCD. I'm like a Virgo, you know, I have to have everything in its right place. And all of my books are lined up on the shelf, you know, by height or by color or by category. And, you know, like, I just have to have that. That's just, if I don't have it that way, it makes me feel anxious. That's totally valid. That may be part of a personality preference, right, or characteristic, but, you know, okay, so not having things lined up or put away or put together causes someone to feel anxious. But true obsessive compulsive disorder, the obsessions and compulsions are time consuming to the point that they're impairing functioning. So if somebody is in their apartment and they arrange all the books in a certain way and then rearrange all the books in a certain way and then come back and pull out their measuring tape, and now they're measuring it so that each book is exactly 3/8 of an inch from the front of the bookshelf, and all of the book jackets need to be folded, you know, in a way that the jacket is behind the cover and it's not, there's no pages in between there. And this goes on for days, and the person is missing work, and they were supposed to have lunch with their mother and they didn't show up. And that kind of time consuming is what moves into the realm of a true mental health condition. So again, clinically significant distress or clinically significant impaired functioning. Now, obsessive compulsive disorders often include elaborate rituals that are designed to reduce anxiety. There's a picture right there of lining up peas, taking peas out of the pod and lining them up in very exact rows. That's another component of OCD, is that these rituals are done, and ritual meaning done with intention for the purpose of reducing the anxiety. Now, let's talk about obsessions and compulsions. So obsessions are persistent, meaning continuing to happen in spite of not wanting to think this way. So persistent thoughts, impulses, or images that the person experiences as intrusive, unwanted, senseless, or confusing, and they're attempting to ignore and suppress them. So a true obsession means I have no control over my brain. It continues to keep throwing this image at me again and again and again. Or I keep having this thought over and over and over again. And I hate it. Like, I don't want it. Stop, brain. Stop thinking about it. And I can't stop it. It just keeps coming anyway. So looping thoughts about, you know, something being contaminated or dirt, you know, having repeated thoughts of just doubt about whether I'm right, whether I'm going to be able to do this. Again, many times people think about things like that. So if I look around my desk in my office and I'm like, oh gosh, I haven't, you know, like wiped this desk off with Windex in many months, and I've eaten my lunch here, and oh my gosh, look at all my books, and I see the layer of dust on my bookshelf. Wow, it's dirty in here. I need to take care of my office. And as I drive to work the next morning, I think about it and I grab the Windex because I need to go to my office. That's not an obsession, right? Whereas I can't even work because of the level of disorder that's in my office. And I have to, like, even though I got a deadline and I have to get this done today, I got to clean it right now. And then when I start cleaning it, I can't stop thinking about like, well, all the other places and the dust behind the books. And now it's overwhelmed me. I'm not only not getting my work done, but I haven't gone home. My wife wonders where I am, et cetera. That's what a true obsession looks like. And for most, the obsessions cause very marked anxiety or distress. So not a little bit of anxiety or distress, but a very significant level of anxiety and stress. Compulsions, on the other hand, are repetitious and deliberate behaviors or mental acts that the person feels driven to perform either in response to an obsession or according to rigid rules. And these compulsions are very difficult to stop. So the goal of the compulsive behavior or the mental act is to reduce distress or prevent a dreaded situation from happening, but it's excessive and it's not connected in any logical way to this goal. If somebody is obsessed about the idea that they are going to see a car accident on the way to work, and they can't stop thinking about this car accident in their own mind, they're seeing people have died and there's blood, and they can't stop thinking about it. And every time they're getting ready to get in a car, they're just convinced that there's going to be a car accident and they're going to experience this car accident. They're going to see it and it's going to be really distressing to them. So what they do is before they leave, they go into the kitchen and they, each of the burners that are on the stove, they turn it to the left, to the right, and off. Then the next one is left, right, off, left, right, off, left, right, off. And the act of doing this makes them feel like now that they did it, they're not going to see a car accident while they're on their way to work. So that would be an example of a compulsion, a deliberate and irrational behavior that's being done to reduce distress or prevent a dreaded situation, but it doesn't make any sense. It's not connected in a logical way to this goal. So being worried about getting into a car accident and making sure that you put on your seatbelt every day, I mean, that is a repetitious and deliberate behavior. Every day I'm putting my seatbelt on when I get in my car to go to work, but that's logical. It makes sense. And that making me feel less anxious about getting into an accident makes sense. So again, true OCD, the compulsions don't make any sense and it's really excessive. So there are some specific kinds of compulsions that typically show up amongst people who have obsessive compulsive disorder. There's varied compulsions for sure, or varied obsessions for sure, but cleaning, obsessed with cleaning, which is being driven by this thought process that things are contaminated and I have to clean. And even though I cleaned everything in my office, bottom to top yesterday, didn't meet my deadline, didn't go home to see my wife, caused lots of problems. My wife didn't know where I was. She called the campus police. The campus police came and I had broken everything down in my office into little piles because I was cleaning all the corners of the dust and put everything back together again. The next day I sit down to do work and suddenly I can't stop thinking about how dirty the office is, right? So again, that kind of logical, illogical, obsessive. Symmetry, the obsession with things being equal and ordered, counting things, repeating things, putting things in a certain order. Forbidden thoughts, so obsessions or compulsions around having bad thoughts like sex or aggression. I don't want to think about that, but I keep thinking about it. I can't stop thinking about it. And then the only way for me to stop thinking about it is to engage in some kind of a compulsive or deliberate act to stop the thoughts from happening. So obsessive compulsive disorder, true obsessive compulsive disorder, is really debilitating and really hard for the person that's living with it. It creates massive anxiety, lots of problems. The challenges with doing basic activities of daily living are significant. So the treatment for OCD, medication management, again, is number one. There's some really good medicines out there now for OCD that'll lessen the severity and the intensity of the symptoms. Exposure and response therapy is, basically gradually with a therapist in a very controlled way, exposing them to the source of their obsessions or their anxieties and teaching them how to modulate their response in a logical and healthy way versus a compulsive way. Mindfulness and emotional regulation techniques, cognitive behavioral therapy, again, transcranial magnetic stimulation or TMS, and psychoeducation and support groups. All right, the schizophrenia spectrum and the other psychotic disorders. Schizophrenia and the other psychotic spectrum disorders, there's a number of them. They commonly co-occur with substance use disorders. And many substances of abuse can cause or exacerbate psychotic symptoms. So if somebody doesn't have a true psychotic disorder, but they have a methamphetamine use disorder, and they have been using methamphetamine every day for the last 21 days and barely sleeping, they are going to have psychotic symptoms. That is definitely going to happen. But one of the problems is that some people who do have a psychotic disorder and they're using drugs and alcohol, it really exacerbates or makes those psychotic symptoms much, much worse. So somebody with mild schizophrenia who develops a cocaine addiction may, develop a full-blown paranoia, closing the shades of all their windows and doors, buying firearms, threatening the mailman, when the mailman shows up because they think it's the CIA. So there's a lot of this exacerbation and co-occurring dimension where people who have psychotic disorders use drugs and alcohol, which tends to exacerbate the psychotic symptoms or cause even more psychotic symptoms. It's common, but despite this common co-occurrence, they're often really under-recognized and undertreated, which leads to poor treatment outcomes. Meaning that most of the time when people come into substance use treatment and they have psychotic symptoms, there's a tendency, even among the mental health clinicians and the psychiatrists, to dismiss those as drug-induced, particularly if the client's using any kind of a stimulant. But it causes schizophrenia and things like that to be underdiagnosed. And the assumption is, oh, you're still having pause symptoms. And it's very serious in this case that we make sure that we identify psychotic disorders for what they are, because they're extremely debilitating. These are sort of the characteristics of severe, persistent mental illness. So it is important then, as I was just mentioning, to make sure that we get clinicians and psychiatrists engaged at any sign of psychotic symptoms, even if they've recently detoxed. Stabilization and mood stabilizing medications are often necessary for treatment success, whereas the psychiatrist may put someone on an antipsychotic medication, even if they've just gotten out of detox for a methamphetamine use disorder, just to ensure that the symptoms are lessened and we get a chance to figure out who this person is, versus just dismissing, oh yeah, they're having that because this is post-acute withdrawal syndrome. Okay, so the schizophrenia spectrum disorders, which includes brief psychotic disorder and delusional disorders and some of the other ones that are there, they're all characterized by at least one of the 5 following symptoms: delusions, hallucinations, disorganized thinking, negative symptoms, and grossly disorganized motor behavior. So let's talk about each of those in turn. These are the things that we would be looking for to try and determine if there might be a psychotic disorder. So a delusion is a false belief about reality that's firmly held despite of what almost everyone else believes or in the face of contradictory evidence. So in schizophrenia, those delusions are often persecutory. Someone is trying to get me. Referential, meaning that the delusion, this false belief, is somehow directed at me. So I believe I'm reading a book and I read a passage in a book and I believe somebody put that in the book because they were trying to deliver a message to me. Or I'm watching television and I see a commercial, for, I don't know, a mattress or something like that. And the person is looking at me and saying, I know what you need to get a good night's sleep. And suddenly there's this belief that, somebody specifically planted that person there, to say something to me because somebody's trying to kill me at night, right? That would be referential. Paranoid is believing you're being threatened by someone or something without any kind of corroborating evidence, or bizarre. So again, delusions, these false beliefs about reality. Something is happening in spite of the fact that nobody else can see it. If somebody believes that someone is repeatedly breaking into my apartment and they are removing silverware. And then they break back into my apartment and they put the silverware back. And there's no evidence that anybody's broken into the apartment. I lock the door when I leave. I unlock it when I get home. But I know it because I open up the silverware drawer and I can see that it's been moved. The spoons are not where I left them this morning. They're in a different spot. And I'm convinced. But I talked to my wife, and my wife's like, honey, the spoons have always been there. Like, that's, nobody moved the spoons. No, I know it, like, and I can see the carpet has been slightly moved at the front door. Like, the carpet is where it's always been. So my wife's challenging my belief, as even though I believe it, there's no evidence, right? Or she disagrees with the evidence that I'm giving to prove this delusion. Now, there are two types of delusions. A bizarre delusion is a delusion that there's really no evidence that could even be attached to that. So believing you're abducted by aliens. I know a lot of people think they've been abducted by aliens, but a bizarre delusion that I've been abducted by aliens last night, and there's just absolutely no evidence of that. Whereas a non-bizarre delusion is a misinterpretation of reality, but there is some anchoring in reality. So thinking that the person on TV is talking about me, I am actually watching a TV and there is a person talking on the TV, so that makes that a non-bizarre delusion. All right, hallucinations are sensory perception-like experiences that occur without an external stimulus. So like you're hearing and seeing things that are not actually there. So hallucinations can be any one of the five senses, but typically auditory hallucinations are most frequent. So you're hearing something that doesn't actually exist, and auditory hallucinations often take the form of contemptuous or threatening voices, or a running commentary on the person's thoughts or actions. So the belief is that somebody's talking to me, somebody's in my mind, somebody keeps telling me that I'm stupid or I'm not going to succeed at this or something like that. There can be all kinds of other hallucinations too. Tasting blood in my mouth, even though there is no blood in my mouth, and I open my mouth and I look at it and there's no blood there, and I'm drinking my tea and I'm convinced that there's blood in my tea, and my wife drinks my tea and she's like, honey, there's no blood in here. Like, it's just the same tea that you always drink. So that would also be a variation of a hallucination. Seeing things that, you're not actually there, feeling touch of something, somebody keeps touching my arm, somebody is putting their hand on my back and there's nobody there. Those are all examples of hallucinations. Now, it's just as a note, illusions are not hallucinations. So misperceiving reality, so misperceiving that a coffee cup is a mouse when I look at it quickly, that's not a hallucination. That's an illusion, and illusions are not associated with the psychotic disorders. There's a very creepy picture of a visual hallucination. I see somebody in the mirror who appears to be washing their hands, but they're not actually standing next to me. Now, disorganized thinking, you're going to notice it's evident from the individual's speech. And I'll try to see if I can mimic this. So one aspect of disorganized thinking is jumping from topic to topic without a transition. So I'm in the middle of talking about this PowerPoint, and the Atlanta Braves won the World Series this year, which was interesting because Houston was the opponent, and Oscar the Grouch totally, like, I think he was doing something, man. That guy was creepy while he was there. And so you see how I'm kind of leaping from topic to topic and there's no natural transition. So if there was something in here that made me think about baseball and I said, oh yeah, and actually that reminds me, I was thinking about that. It's interesting this year that the Atlanta Braves won this, or actually there was a funny, I don't know why I'm thinking about it now, but somebody was telling me this theory that Oscar the Grouch, was like a CIA agent, in Sesame Street. So what I'm doing there is I'm giving little transitions to explain that I'm about to jump to a different topic. So true disorganized thinking is leaping from topic to topic without transition. Incoherent or highly confusing comments that are nonsensical. So they don't apply to this. So the thinking phrase of cadet is the phone, man. So here that's incoherent, right? The comment doesn't seem to actually be related to anything. It's nonsensical. I can't apply it. Answers to questions that are completely unrelated to the topic. Would you like a cup of tea? It was Breville. Breville ultimately was the one that made the Cal Plus flyers, right? Totally unrelated to what I just asked. Slipping off track from one topic to another in mid-sentence. So you're in the middle of talking about something, and then the student will only know the key phrase if now I'm back on the topic again. That was not the key phrase, by the way, for those of you who might be trying to pick that out. But there, what I did was I slipped off the track and didn't complete my sentence, and I'm on to another one. And then true word salad. Sometimes, even if you haven't experienced someone who's got a severe form of schizophrenia, you've probably seen it depicted on movies or pictures. Movies or videos where the person is just, it's sometimes referred to as word salad. The words are completely jumbled, and ultimately the Evo baseball of the Atlanta and the detailed outlook of the 43. So everything kind of jumbled together. So any evidence of these things is characterized as a form of disorganized thinking, and it's characteristic of all of these psychotic disorders. Grossly disorganized or abnormal motor behavior. Interesting research about the psychotic disorders and some of the brain research where you see abnormalities in the area of the brain that's also associated with movement, motor movements, body movements. So this can take several forms: unpredictable agitation, kind of the classic person with schizophrenia who's pacing around and they're wringing their hands and they're talking in a very disorganized way. That would be abnormal motor behavior. Markedly disheveled appearance, not showered, hair grown out, the person peering in a really odd way, standing in really rigid or inappropriate postures, staring or grimacing facial expressions. Clearly inappropriate sexual behavior is typically underneath this category too. Somebody masturbating in public, in the middle of a public park with seemingly no awareness of what they're doing. And then catatonia, which is when somebody's truly in a catatonic state, they're not moving. They're like absent, different from dissociation, like really just staring off into space, not responding when you wave your hand in front of their eyes. Their heart is beating and they're breathing, but otherwise they're fully catatonic. And then the last one is referred to as negative symptoms. So a negative symptom in a clinical term related to the psychotic disorders means there's a severe restriction in the range and intensity of emotions and other functions. Sometimes you will hear blunted affect. That phrase is used as an example of a negative symptom. So a blunted affect means that the emotional expression is limited. The person speaking in the same level, there's very little variance in what they're saying and how they're saying it. I'm feeling really angry right now about this, and also it makes me kind of excited. So, I mean, that's kind of an exaggerated version of a blunted emotional expression. Anhedonia is the decreased ability to feel and experience pleasure. Asociality is a complete lack of interest in social interactions. And I'm not talking about I think I'm going to stay home this Friday night rather than go out with my friends. This is just not engaging socially at all. Going up to the counter to buy a pack of gum, and the person behind the counter says, "Hey, how you doing today?" And there's zero response. And I fumble out my money, and the person's like, "Yeah, great. You're a sociable one, aren't you?" And I still have no response. And then I just push the coins over and I take the gum and I walk out the door. So that would be asociality. Abolition, restricted initiation of goal-directed behavior, meaning that I don't do anything unless I'm told to do it, including things like eating, right, or lifting the fork up to my mouth. And alosia is diminished speech output. That was not your microphone there that was doing that. That was me. So diminished speech output. I'm not really speaking about anything. So that would be an example of a loja. All right, so the evidence-based treatment for schizophrenia and psychosis, stabilization and medication management, again, with the severe persistent mental illness, meds are really super important. CBT, practicing distress tolerance, interpersonal effectiveness skills, teaching people how to behave appropriately, ECT, vocational rehabilitation and supported employment. This is really important. People with schizophrenia and psychotic disorders typically are not able to keep jobs. There's a lot of stigma behind this. Schizophrenia is usually when the untrained and uninformed person says somebody looks crazy, what they're describing looks like schizophrenia. And so finding jobs where they can work in an organized way, where they're not being stigmatized, is really helpful for treating symptoms and psychoeducation and support groups. All right, the neurocognitive disorders. So the neurocognitive disorders I'm talking about here because of how often they appear among the older population of people who are in treatment. So the number of older adults who are in need of substance abuse treatment is increasing. It has increased substantially since 2001. We're seeing, upwards of 4 million additional people now in treatment that are considered older adults, 60 years old or older. There is a 50% increase in the number of older adults in the United States and a 70% increase in the rate of treatment among these older adults. So the reason why I'm talking about this is because many of our elder clients have neurocognitive disorders. So a neurocognitive disorder is a deficit in cognitive functioning that represents a decline from previously attained level of functioning. So a deficit in cognitive functioning means that you are not thinking the way that you used to think. Now, that's a normal part of aging. Everybody who's moved into their 30s, 40s, 50s have noticed diminished cognitive capacity. That is totally normal. It's an unfortunate fact of life. The brain ages, and as it brains, we don't think as fast as we used to. We're not as good at things like video games, et cetera. So what we're talking about here is a much more severe deficit in cognitive functioning, representing a decline from previously attained level. So if somebody was an accountant for 30 years in their career, and now they can't do basic addition, or they're having a hard time figuring out how to make change for somebody, if they're changing a dollar bill, that would be a significant deficit in a cognitive capacity where they previously were showing skills. So there's a couple of main categories of cognitive functioning where you see these kind of severe neurocognitive deficits. Complex attention means your ability to sustain attention, divide attention, meaning do two different things at once. Selective attention, sitting in a cafe and being able to focus on my book, versus focusing on the conversation of somebody sitting next to me. And processing speed, how fast your brain is moving. Executive functioning is planning, decision-making, having mental flexibility, being able to think your way around corners, responding to feedback, correcting errors. Wait, nope, that's a misspelling. I need to go back and correct that. That's all associated with executive functioning. Again, with the neurocognitive disorders, we're looking for significant impairment when it's obviously a decline from what they were earlier able to do. So if a person previously, was a managing director of a paper mill company and they had 50 employees under them and they were able to keep track of inventory and, coordinate what was going on, down on the floor, the factory floor, and now they're having a really hard time, with working on step 2, this an assignment that you've given to work on step 2 in the 12 steps. Where they don't simply even understand what's being asked of them, or any one of the other steps. So the idea here is not to run off on that. I was just realizing step 2 may or may not be appropriate for what I just said, but I don't want to get into the the whole 12 steps. So the idea here, though, is that they're showing a severe decline. So learning and memory, Language, expressive language, naming, word finding, fluency. Again, normal as you get older to forget people's names, to struggle with finding the word. This would be significant decline. Perceptual motor, the ability to interact with the environment using senses and motor movement, eye-hand coordination. Somebody is trying to count out change, to purchase something at the store, and they can't talk to their friend while they're doing that. Like they really can't talk to their friend. They have no idea what their friend just said because they can't interact with the outer environment as they're using motor coordination. And social cognition, recognition of emotions, and the ability to consider somebody else's mental state or mental experience. Now, when you see this in a very significant way, it's called major neurocognitive disorder. This is formerly called dementia, where it severely impacts the ability of one to stay independent in everyday living. It's not likely you're going to see major neurocognitive disorder in a substance use treatment facility. Alzheimer's disease and Parkinson's disease are primary sources of major neurocognitive disorder. And when those move into the realm where the deficits are so severe, typically the person has to be in some kind of assisted living or nursing home setting. So you probably won't see that there. But you may see mild neurocognitive disorder, where this is over and above what would be considered normal aging, but they're still able to maintain independent living. They just have a significant decline in one of the major cognitive domains. Now, it's important with the neurocognitive disorders, both mild and major, to engage a neurologist or a neuropsychologist if you suspect anything like that is happening. Major neurocognitive disorder is definitely going to require a medical intervention that's likely going to preclude substance use disorder treatment, meaning if somebody is in your facility and they are showing signs of full-blown Alzheimer's, then probably they're not going to remain in substance use treatment. They're going to need to get that Alzheimer's treated first. But mild neurocognitive disorder, which is the population most likely to be in treatment, you just may have to make accommodations for learning and processing speed. So if you've got a 70-year-old person who enters your outpatient treatment program and they're having a really hard time, with the step work assignments that you've given them, and they're getting frustrated, and even when you try to talk to them about it, they're still not understanding, then you may need to make some kind of an accommodation, do the work with them, or maybe give them a different kind of assignment because there's evidence of mild neurocognitive disorder. Again, with either of these, you want to engage a neurologist or a neuropsychologist, which most treatment facilities are not going to have on staff. If you have a clinical psychologist, they may have gotten training in doing this, but otherwise you're probably going to need to engage with an outside physician. The treatment for mild neurocognitive disorder, stabilization, med management, providing psychoeducation about this in support groups, distress tolerance, motivational interviewing, and then again, vocational rehabilitation and supported employment. Again, clients with mild neurocognitive disorder can generally participate in substance use disorder treatment. They just need more time on tasks, more repetition, short, simple words versus abstract concepts, checking with their comprehension, reducing distractions, avoiding multitasking, and using to-do lists, alarm clocks, and calendars. Okay, so what we're going to do here is talk about serious and persistent mental illness, which are less common conditions than you're going to see in treatment, except for the first one I'm going to talk about, which you are definitely going to see a lot about. But before we move on, for those of you who are watching this video as part of a course at San Diego City College that you're receiving credit for, this is the key word or the key phrase non sequitur. You're going to be tested upon the conclusion of this video, and one of the questions is going to ask for the key word or the key phrase. This key word or phrase will not be on the PowerPoint, and you're only going to know it if you actually watch the video. So the key phrase for this video is engage. For those of you who are Star Trek fans, kind of like what Captain Picard would say, engage. E-N-G-A-G-E, engage. All right, now back to our scheduled programming. So for the mental health conditions that are listed on the following slides, the alcohol and drug counselor is going to want to consult with other mental health professionals for integrated treatment. These are more severe mental health conditions that typically will get in the way of completing substance use treatment if you don't involve some kind of supplemental or additional treatment. However, almost all of them will benefit from motivational interviewing and solution-focused counseling approaches, as well as DBT, CBT, and contingency management interventions, each of which an alcohol and drug counselor can definitely use as long as they've been trained in that technique. So the first one we're going to talk about is trauma and stressor-related disorders. And the big one here is PTSD. Now, PTSD is definitely not one of those ones that you are not going to see in treatment. You are going to see a lot of PTSD in substance use treatment. The reason why it's included here is because PTSD is considered a severe and persistent mental illness. When somebody has PTSD, it really changes the way that the brain is wired. And it is a long-term condition that takes long-term management. So I'm not going to get into a super detailed description about PTSD, but we are going to talk about some of the major symptoms here. When you think someone has PTSD, you are definitely going to want to engage a trauma therapist in the course of their treatment. So to be diagnosed with post-traumatic stress disorder or PTSD, it requires exposure to actual or threatened death, serious injury, or sexual violence in one of the following ways. The person has directly experienced the event, they have witnessed the event in person, meaning they were there, they learned that the event happened to a close family member or a friend, or they have had repeated or extreme exposure to aversive details of the event. They hear about it over and over and over again. Now, these definitions are taken from the DSM-5. I will definitely talk before I'm done with PTSD about PTSD symptoms or trauma symptoms where a person hasn't actually experienced one of these things in one of these ways. But this is the definition of PTSD in the DSM-5, which is a bit controversial, which I'll talk about. But threatened death, serious injury, sexual violence, experiencing that. And it leads to different categories of symptoms. So the first one is the intrusion symptoms. So PTSD, when someone has PTSD, they are having recurrent, involuntary, distressing memories of the event. So they can't stop themselves from thinking about whatever the traumatic event is. There are recurrent, distressing dreams related to the event. There are dissociative reactions in which the person feels or acts as if the event is recurring, meaning that the person nearly died. They were in a car accident in which other people, did die, and they witnessed death, but they themselves didn't die. That would kind of be a classic PTSD scenario. And so a dissociative reaction in which the person feels as if the event is recurring. They may be sitting in a classroom and suddenly feel as if they're in a car and they're sort of out of the classroom in their mind now, and they're replaying a memory of that experience, and their heart starts beating and racing, and they start feeling an anxiety response and fear, that they're going to die. So that would be a dissociative reaction, disconnecting from the situation and feeling as if you're back in it. Prolonged psychological distress when exposed to reminders of the event. So prolonged psychological distress, somebody who doesn't have PTSD, but they experienced a traumatic event. I'm trying to think of an example here. Let's say somebody was in a military zone, but they don't have PTSD. But they get together with their friends and they say, hey, let's watch a movie. And then, they turn on, they're like, hey, let's watch one of some war movie that's out there, Black Hawk Down, right? Like, hey, let's watch Black Hawk Down. And, the movie starts and the person who does not have PTSD says, hey, man, I can't watch this actually. It's too close to home. Can we pick a different kind of movie? And so when they first see it, it causes some distress, but then when they change the movie, the person isn't experiencing psychological distress. Now, let's say that they did have PTSD and they get caught by surprise. They don't know what the movie's about. It suddenly starts playing, and now they get really triggered by that. And then they're like, I can't watch this, man. And their friend says, okay, sorry, and they change the movie. But now the person's having prolonged psychological distress. They're still having a big trauma response, and they leave their friend's house. They're like, you know what, I need to go home. And they're in their car and they're having a trauma response. They get home, they're still having a trauma response. That would be an example of a prolonged state of psychological distress. Or marked physiological reactions to reminders of the event, like an increased heart rate. So using that same example that I just said, they start watching the movie, they turn off the movie, but now the person's heart is racing as if they're back in a war zone and they can't stop themselves or calm themselves down. So those are all examples of PTSD intrusion symptoms. Avoidance symptoms is another one of the categories in PTSD. So avoidance of distressing memories, thoughts, or feelings related to the event. I don't want to think about this. I'm going to go to great lengths to avoid anything that would make me think about this. Avoiding external reminders that elicit distressing memories, thoughts, or feelings of the events. Those are examples of avoidance symptoms. Pardon me. Cognition and mood changes. Inability to remember important aspects of the event, like parts of the event has been blacked out. Somebody who was physically or sexually assaulted and develops PTSD from that may have an inability to remember what exactly happened while it was happening. It's just like a black spot in their mind. Markedly diminished interest in significant activities after the event. Here the event happens, and now things that you used to really enjoy, you're not enjoying any longer. Persistent, exaggerated negative beliefs about oneself, others, or the world after the event. Somebody experiences an assault and they think not only do they deserve it, but they believe that the world's getting worse, in spite of evidence that the crime rates are getting better. They believe that the world's full of bad people who are just trying to hurt, you, and it's a persistent and exaggerated. Persistent distorted cognitions related to the event's cause or consequences. The most common one here is belief somehow that I brought it on. I'm somehow at fault. And in spite of the fact that my family, my friends, my coworkers are like, dude, it's not your fault. Like, that was totally, it never should have happened. That was just really unfortunate. And I just continue to maintain this belief that somehow I brought it upon myself. Still related to cognition and mood changes, feelings of detachment from others. A lot of people who come back from war zones show this. They're back with family and friends, but they're just really detached. Persistent negative or emotional state, and persistent inability to experience positive emotions. Now, another major category of PTSD symptoms is arousal and reactivity. So experiencing hypervigilance, which is basically being in a constant state of alarm and state of alert, always feeling like you're on guard. Irritable behavior and angry outbursts, reckless or destructive behavior. I'm continuing to use the example of somebody who came back from a war zone with PTSD, and they buy a motorcycle and they ride their motorcycle 100 miles an hour on the freeway, zipping in between cars, and then they're popping wheelies. That would be an example of reckless or destructive behavior. And it's actually related to the arousal experience of PTSD. Without getting too complicated and off on a tangent about this, it's essentially causing an extreme nervous system arousal, but being done under my control versus having it happen to me as a kind of unconscious attempt at re-exposure. Exaggerated startle response, you hear a noise and have a really significant startle response, impaired concentration, and sleep disturbance. And the last category is the dissociative symptoms. So the dissociative symptoms with PTSD is dissociation, meaning you're psychologically not there anymore. The example I gave earlier on of I'm in the classroom, I'm sitting in the classroom, but I'm not there mentally. I don't feel myself there physically anymore. I've left reality in my psyche, my mind in some way. Depersonalization is feeling detached from yourself as if you're an outside observer, feeling a sense of unreality of self or body. People who have been assaulted often experience depersonalization, where during the assault, they may have felt detached from their body, and after the assault, they are continuing to have feelings as if they're there. There's recognition that I'm here, I'm not fully dissociated, but I don't feel like I'm me, or I don't feel like I'm in my body, or my body isn't mine. And then derealization is experiencing surroundings as unreal, dreamlike, distant, or distorted. So the person's sitting in a classroom and all of a sudden the classroom seems weird. It seems unreal or fake in some way, even though like the professor's still up there and my classmates are sitting next to me, like my perception of it is not the same. This doesn't feel like a real classroom. It's dreamlike in some capacity. Okay, so complex trauma. So I mentioned earlier that some people might see the symptoms and the criteria for PTSD and recognize that I haven't had those experiences, but I've been traumatized, or somebody that I know has a lot of those symptoms, but they didn't get it from any of those things. So the controversy behind this, which this is a long lecture, so I'm not going to spend too much time on this, is that when the DSM-5 came out, there had been all kinds of discussion about including complex PTSD or complex trauma, basically expanding out how we define PTSD, because there's a lot of people who don't have necessarily those same experiences, but they have experienced trauma and they've got all the symptoms of PTSD. And it did not get included in the DSM-5, which a lot of clinicians were really upset about. So I just want to talk for a second about what's commonly referred to as complex trauma or complex PTSD. You won't find it in the DSM-5, but it definitely shows up. So complex trauma describes long-term exposure to multiple occurrences of maltreatment, either simultaneously or sequentially over time. So multiple occurrences of maltreatment, intimate partner violence or domestic violence that doesn't rise to the level of sexual violence, but it has emotional violence, psychological violence. We have a whole lesson on DV and IPV in our family counseling class where we talk about how SAMHSA and the CDC recognize that violence doesn't have to be physical or sexual in order to cause long-term damage. Emotional and psychological violence is equally damaging and traumatic, to bring it back to what we're talking about, but you won't see those listed as something that is criteria for PTSD, but it does fall under complex trauma, where long-term exposure to maltreatment in some way, which can include repeated acts of emotional abuse and neglect, sexual abuse, physical abuse, witnessing domestic violence, being forced into sex trafficking, prostitution, concentration POW camps, and many, many other things. Basically anything else that causes a trauma experience and symptoms of trauma afterwards is under the umbrella of complex trauma. So complex trauma causes lots of problems. So for children who experience complex trauma, it disrupts a lot of normal physical, emotional, mental health development. It can interfere with a child's ability to form secure attachment bonds, and it affects social emotional relationships with others. So children experiencing domestic violence, for example, their parents are engaged in a domestic violence relationship, causes lots of problems. Their physical, emotional, mental health development can be delayed or disrupted in some way. They may have problems emotionally acting out in school settings and things like that, difficulty making friends with other people. And it's because they're showing trauma symptoms from what we would refer to as complex trauma. Outside of just children and adults, complex trauma affects the foundation of self-identity, feeling completely different from other people in some way. Often includes a sustaining sense of hopelessness and despair. So the important thing for alcohol and drug counselors is to recognize that there are trauma experiences people have that may not fit into any category or a DSM diagnosis, and that doesn't matter. It's not our job to define trauma. If the person communicates in some way that they've experienced trauma, then we're going to treat it as trauma, and we're going to practice good trauma-informed care principles. And so whether they actually meet the strict criteria for PTSD or not, it is very important that we refer somebody who has experienced PTSD or complex trauma to a trauma-trained mental health clinician. It is very difficult to treat PTSD and complex trauma without trauma-specific therapy and interventions. This is a study from the National Center for PTSD. And so what they did was they had a group of people who were diagnosed with PTSD, and they gave them either 2 different kinds of treatment or no treatment at all for 3 months. And they found that 53% of people who received trauma-focused psychotherapy, which includes things like cognitive reprocessing, prolonged exposure, EMDR, 53% of people who received trauma-focused psychotherapy no longer had PTSD symptoms after 3 months. So that's not 100%, but that's a significant number. That's a little over half of the people who received trauma-focused psychotherapy got better after 3 months. 48% of people who received medications, so no trauma psychotherapy, just medications. So again, a little less, but still about half of the people that received medications no longer had PTSD symptoms after 3 months. But their control group was people that did not receive trauma-focused psychotherapy or medications. And only 8% of people who didn't receive one of those 2 interventions no longer had PTSD symptoms. 8%, meaning that pretty much everybody that had PTSD still had PTSD 3 months later if they hadn't had some kind of a trauma-specific intervention. And so that's why it's so incredibly important when we're working with clients in substance use treatment and we identify PTSD or complex trauma symptoms that we get them connected to a trauma therapist. Note that a mental health clinician is not necessarily a trauma therapist unless they've gotten additional or supplemental training in trauma therapy, which they will identify that as a trauma therapist if they provide that kind of a service. All right, talking about other complicated mental health conditions that I'm only going to give a brief overview, leads us into personality disorders. So the DSM defines a personality disorder as an enduring pattern of inner experience and behavior that deviates markedly from the expectations of an individual's culture. Now, that's kind of a fancy phrase, but basically an inner experience and behavior means the way that I'm perceiving the world and other people and the way that I'm behaving towards the world and other people is off. Other people don't think this way or act this way. It's a significant deviation. So adding to this definition, the DSM defines a personality disorder as having personality traits that are inflexible, very resistant to change and treatment, and maladaptive. And you put those 2 things together, and essentially what it means is that somebody with a personality disorder, their essential aspects of themselves, their personality, their way of perceiving the world, their way of acting, is causing significant problems in the way that they're interacting with the world. And they are resistant to changing that way of thinking or acting or interacting with the world. So the way that they think and perceive and act with the world is different than how other people do it. It's maladaptive, it's causing problems, and they're resistant to changing that in any significant way. Personality disorders are very difficult to treat and difficult to work with. So in order for it to be truly a personality disorder, it must cause clinically significant distress and impairment in important areas of functioning, meaning you need to see that this way of being, this way of perceiving and acting with others in the world, which is a markedly different way than other people do, has to be causing problems in their social relationships, their relationships, their work, etc. So what I mean is, I'm not talking about somebody who's just kind of quirky, or somebody who's kind of dominating, or somebody, who's arrogant. That doesn't necessarily mean that it's a personality disorder, but somebody who is consistently running into problems in the way that they interact with the world, and it's inhibiting their ability to maintain relationships, maintain jobs, maintain family relationships. And in spite of all of that, they insist that the way that they're, seeing and acting and doing things is right and everybody else is wrong, essentially. A personality disorder means that the pattern is stable and long-lasting. It can be traced back to at least adolescence or early adulthood, which is when personality disorders first emerge. And I just want to make a note that they are highly stigmatized in the clinical community. A lot of people don't want to work with others who have personality disorders, but we need to recognize that the symptoms of personality disorders cause serious distress for the people that have them. Now, the way the problems manifest have to manifest in at least two of these areas to have a personality disorder diagnosis. So the first two are really important. Cognition, the way of perceiving and interpreting yourself, other people, and events is causing problems, and other people don't see it that way. And you're resistant to changing the way that you see it that way. So that would be the cognitive domain. The affective or affectivity domain is the range, intensity, lability, and appropriateness of emotional responses. So what that means is the emotional responses are too intense, too broad, too over the top, too back and forth. They're inappropriate to what the situation is. Interpersonal functioning. So we're seeing problems manifesting in the way that the person interacts with other people. And impulse control. So the way, again, that they sort of perceive and interact with the world is causing problems with managing their impulses. Now, the DSM-5 groups personality disorders into clusters, meaning that certain personality disorders have similar symptoms. Again, I'm simply giving you kind of a real cursory survey of what the personality disorders are. This could be a very long PowerPoint and lecture presentation all on its own. But cluster A are the odd eccentric personality clusters, paranoid, schizoid, schizotypal personality disorders. These are the people that really stand out usually as odd and very eccentric. Cluster B are the relational personality disorders, where what you're seeing is dramatic, emotional, unstable, or erratic behaviors that really manifest in terms of how the people interact with others in relationship. So this includes antisocial personality disorder, borderline personality disorder, histrionic, and narcissistic personality disorder. And then cluster C are the anxious and fearful personality disorders. So here we're seeing people who are really having a lot of high anxiety about how they engage with the world at large. So avoidant, dependent, and obsessive compulsive personality disorders. Now, the most common personality disorders that you're going to see in substance use treatment are two. Antisocial personality disorder, which is essentially defined as a pervasive pattern of disregard for and violation of the rights of others. It doesn't mean you don't want to hang out with other people. It means that you see other people as weak, as what phrase I'm trying to say? When you're being predatory towards other people. So this is that middle age thing that I was talking about earlier. Seeing the world as something to take advantage of, seeing other people as weak. Many people with antisocial personality disorder ultimately end up in trouble with law enforcement. Many of them end up in prison, but a lot of them end up then in drug court types of programs or early release type of substance use treatment programs. And the go-to primary intervention is to use contingency management. There's evidence that contingency management is the best primary intervention with good outcomes for antisocial personality disorder. And then the other one that you will see in substance use treatment a lot is borderline personality disorder, where you see a pervasive pattern of unstable relationships and unstable emotional states with marked impulsivity. People with borderline personality disorder have a very hard time relating with other people. There is all kinds of characteristic problems. There is inappropriate anger. There's demand that other people need to respond, which also then flips into feelings of, hurt and loss, and, why can't I ever have anybody, who cares about me and loves me, and then flips back into, everybody's, terrible. Often flips from really idealizing other individuals in the beginning and then flipping very quickly into there's something really wrong with you. The emotional reactions are really over the top. There's all kinds of instability. It's a very challenging personality disorder to have. So dialectical behavioral therapy, or DBT, was specifically created for borderline personality disorder, and it is the frontline primary intervention. For those working in substance use treatment who have not been trained in DBT, firm and empathetic boundary setting, meaning that it needs to be very clear what is okay and what's not okay. But at the same time, people with borderline personality disorder are really distressed underneath all of this. And so being empathetic to the fact that I understand you're very angry with me right now, I understand this is very upsetting, and you think it's incredibly unfair. I get it. Unfortunately, by skipping group 3 times this week, that does mean, that at this point it leads to a termination of services. You can appeal, and we want you to do that. We want you to stay in treatment, but you actually have to come to treatment. So that would be an example of setting a firm boundary while still expressing empathy and trying to welcome the person to stay in treatment. Okay, a couple more of the rarer but still very important and significant mental health conditions that you would need to intervene. The neurodevelopmental disorders. So neurodevelopmental means they are brain disorders that come about when the brain is developing, throughout the course of childhood and adolescence, while the brain's fully coming online. So when somebody has a neurodevelopmental disorder, it typically manifests in early development before they enter grade school. And what happens is it produces these deficits that cause impairments in how the person functions personally, socially, academic, and occupational. Problems with learning, intelligence, social skills, memory, problem solving fall under the neurodevelopmental category as well. It's another one that's very complicated and very complex. We could do a very long entire lecture on this alone. Again, just a cursory evaluation of the things to be aware of. So the first one is adult intellectual disability. So an adult intellectual disability, being a neurodevelopmental disorder, would have started earlier in childhood. But what you're seeing in an adult substance use treatment facility is that the person is showing deficits in general mental abilities. So general mental abilities mean your ability to reason through something, do basic problem solving, maintain attention, understand abstract thinking, being able to learn from experience. Now, this has to be confirmed by clinical assessment and standardized intellectual testing. So if there's concern that somebody has an intellectual disability, you are going to want to refer to a neurologist and a neuropsychologist who can do the type of testing necessary to determine if, in fact, they do have an intellectual disability. A severe adult intellectual disability, you're probably not going to find in substance use treatment. These are adults who are so incapacitated, they need to live in a social environment, usually with 24-hour supporting care. But you may find people who have a more mild intellectual disability, an IQ, the median IQ is 100. So somebody who has an IQ of 80 or something like this, where it's not severe, but they're having real problems in your treatment facility. They're not able to follow directions. They seem not always to be able to get it. They're having trouble with assignments. They really aren't understanding some of the psychoeducational lessons. So if you think you have something like this, by asking questions, you are going to get somebody else involved. So in addition to seeing that maybe there's some trouble with learning, understanding, comprehension, a true adult intellectual disability has to include deficits in adaptive functioning, meaning that they are failing somehow to meet community standards of personal independence and social responsibility. What that means is it's often challenging for people with adult intellectual disability to hold down jobs. Things like budgeting money for rent in order to pay rent is really challenging. Not really understanding, when getting a paycheck and going to a check cashing place to cash your paycheck and then spending it all without really understanding that I need that for rent. That would be an example of failing to meet community standards for personal independence and responsibility. So you'll see this in multiple areas. It's often undiagnosed in adult populations and can cause major problems. So as we've talked about, it's really important if you feel like there's somebody in your substance use treatment who's not intellectually all there. They're not following things and understanding things the way that a kind of standard treatment client would. You want to try and engage with somebody else to help. If it can be proved that somebody has an adult intellectual disability, they are going to be eligible for all kinds of social support systems. They can be eligible for supplemental income through the SSI program, which is a supplemental security income through the Social Security Administration. This is different from specific learning disorder, which is having a learning disability. It would be more global problems. All right, I also want to talk briefly about adult autism spectrum disorder. This includes what was formerly called Asperger's syndrome or Asperger's disorder. Adult autism spectrum disorder is also very challenging. It's one of the neurodevelopmental disorders that happen as the brain is developing, and the brain doesn't develop in a normal way. So when somebody has autism, it's on a spectrum. So it can be mild autism disorder or severe autism disorder and everything in between. But all of the autism spectrum disorders are characterized in varying degrees by difficulties with social interactions in multiple contexts. Meaning people with autism have a really hard time understanding verbal and nonverbal cues. What I mean by that is, if I've been going on and on and on, not including this lecture, but let's say that we were talking together in public and I'm going on and on and on, and I just keep talking, and you say to me, okay, Keith, well, it was great to see you, but I'm going to need to wrap this up. And I just keep going on and on and on. I didn't understand your verbal cue of we need to stop now because you need to leave. Or maybe what you're doing is you're going, as I'm talking, and you're not looking at me any longer, and you're gathering up your things. You're my coworker, and I'm standing in your office, and you're like, yeah. Well, getting late, and I'm still not following, and you put your coat on, and I'm still talking, and you start to walk towards me, and I'm still talking. So that would be a difficulty understanding the nonverbal cue of our social interaction. Now it's time for me to stop talking. So this is one example of many examples, but autism spectrum is defined by that, having difficulties understanding social cues, also understanding social emotional reciprocity. So if I am interacting with my coworker and we have a project we need to work on together, and I knock on her door, and she opens her door and she's crying, I'm probably going to say, oh my gosh, what's happening? And she says, oh my gosh, this is really terrible. I just found out that my mother has breast cancer, and I'm really freaking out because my grandmother died of breast cancer. My social emotional reciprocity would be to respond in kind. Oh my God, I'm so sorry to hear that. Like, oh, that's got to be really hard. What do you want to do? Should we work on this? Should we talk to the supervisor and see if we can get a change in deadline? So I'm responding in an appropriate way, in a social and emotional appropriate response. Whereas people with autism spectrum disorder, they usually have difficulties with that. So maybe, somebody with mild autism who is able to work, and they show up and they knock on their coworker's door, and the coworker's crying, and they say, okay, so it's time to work on, the project. Oh my God, I don't know if I can do it. Why? Because I just found out, that my mom has breast cancer. Okay, how does that relate to this project? It's your mom, it's not you, right? So that would be an example of failing social and emotional reciprocity. Also, just overall difficulty with developing relationships, maintaining relationships, understanding relationships, and relating with others. Now, again, it's on a spectrum. People with moderate to severe autism, you probably aren't going to run into in a substance use treatment facility, but you will definitely run into people who have mild autism spectrum disorder, which used to be called Asperger's. So you're going to still hear lots of people who refer to it as Asperger's, which is fine. People who were diagnosed prior to the DSM-5 were probably told by their doctor or psychiatrist that they have Asperger's, which is fine. Just note that it's now called mild autism disorder. It's no longer called Asperger's. So again, moderate to severe autism, very atypical mannerisms. The old movie Rain Man, Dustin Hoffman did a fantastic job of showing what moderate to severe autism looks like. And there are some interesting neurodevelopmental components of the autism spectrum where you see sometimes hyper focus and real exceptional abilities in very narrow areas of life, such as music, math, other types of academic skills. The challenges that you're going to run into with mild autism spectrum disorder is that, well, with all of them, there's often real trouble with change or spontaneity, doing something, that's, on the fly. The tendency to maintain very restrictive, repetitive patterns of behavior, interests, activities that lends a feeling of safety and a feeling of security. And there's often real anxiety in changing things up. Like, for example, if you always do a check-in in your group therapy, that's something that you've always done, and you've got somebody with mild autism disorder. And, today everybody comes into group and you say, okay, so today we're going to start with an activity. And the person may say, wait, we have to do the check-in. Yeah, no, I know we usually do the check-in, but today we're going to start with an activity instead. Well, no, like we have to do the check-in. I mean, I want to do the check-in. Okay, well, it sounds like you want to check in. What did you want to check in about? No, everybody needs to check in. You always start with the person to your right. I'm not to your right. They need to check in first. Then when it comes to me, I'll check in. So that would be an example of a response that might trigger a, like this is an interesting, type of reaction the person's having. Stereotype, repetitive motor movements, speech, insistence on sameness, highly fixated interests. Again, these are all characteristics of autism spectrum disorder. Complicated. It'll stand out to you if it's actually autism. So hyper or hypoactivity to sensory input, jerking away quickly if somebody's arm brushes their arm. A lot of times if it's a crowded group and you've got everybody sitting in a circle and, somebody's elbow touches somebody else's elbow because they're sitting in a circle and that feels uncomfortable, somebody will just pull their elbow away a little bit, right? Create like an inch of space between there. But if you see the person has a very strong reaction to that, like no touching, don't touch me, then you might have mild autism spectrum disorder. Again, this is pretty complicated stuff, but it'll stand out to you. This problem with social emotional reciprocity, this lack of understanding with social relationships, this insistence on keeping things the same way. It's going to need a referral. The 3 referrals of severity in autism spectrum. So level 1 are the ones, again, you'll usually see, and they can certainly function in a substance use treatment facility. They can often live independently, but they benefit from levels of support, including counselors who are trained in autism spectrum disorder. So people with mild autism spectrum disorder can be trained to learn social emotional reciprocity. They can be trained to learn how to navigate relationships better. They can be trained to learn how to deal with changes in routine. Whereas level 2 and level 3 autism are usually pretty severe, and they're going to need ongoing substantial support. Something else that will sometimes pop up in substance use treatment, I personally had this happen a couple of times where somebody had mild autism, is you see confabulation. So confabulation looks like a delusion, or it looks like the person's making something up, but it's actually associated with autism as a memory error, where the person is kind of filling in, their brain's having a hard time remembering how things were or what actually happened. And so they tend to make up stories. They produce these fabricated or misinterpreted memories about oneself or the world. It's actually similar to something that you see in young children who don't have autism, where they start to make things up. So, maybe your sister takes your child to Legoland, and they come back and you say to your sister, how'd it go? And she says, it's great. Like, she had a really good time. She's, asleep right now, brings her in the house. And, your daughter wakes up and, she's 5. And you say, how was Legoland? And she says, it was great. And you say, yeah, what'd you do? And she says, well, Auntie and I saw the Legos, and we had ice cream, and what else? And then we took a trip to Mars. You did, really? All the way to Mars? Yeah. And then we flew back to Earth. And what's happening is normal for young kids, but it's a confabulation. They're creating this fabricated or misinterpreted memory about what happened. And with autism spectrum disorder, you see this too, as a neurodevelopmental disorder, not necessarily with everybody that has it, but it's fairly common. It looks like a delusional disorder. It looks like the person is believing something that's not real. And prior to autism emerging as a distinct diagnosis in the 1980s, many people with autism were actually misdiagnosed as having schizophrenia because of the confabulation. Now, it can be distinguished from lying in that there's no reason to make these things up. There's no intent to deceive, and the person providing this really appears to have no awareness that the information they're providing is false. So this could be subtle, or you could have totally bizarre fabrications. Now, people who have autism, when they're confabulating, they'll usually deliver the information in a very confident way. You're working at a treatment facility with chronically homeless co-occurring disorders, and you have a client who's already showing you signs, that they're not quite picking up on social emotional cues, and they're having maybe even a challenge, because it seems like they've got a lower education, and then they're talking and they say, oh yeah, and I lived in Boston, one day, and I went to Harvard, and I did my classes at Harvard there. You did? You took classes at Harvard. Did you get a degree? Yeah, I got a degree while I was there too. What was your degree in? And so you'll start to then see some anxiety. So at first they seem confident about what they're saying, but now when there's contradictory evidence, you might see some confusion, a flash of confusion, or some anxiety go across their face. So if you're treating someone who has autism spectrum disorder, or you suspect autism spectrum disorder, and they're starting to confabulate, it's usually not helpful to challenge or question the content of those statements, as they may become really upset. And from that, it can really disrupt the therapeutic relationship. They may even leave treatment. So unless there's a really important reason to challenge the reality, it's usually better to just accept the confabulation and then just sort of assist with problem solving and emotional regulation. So in that example, if somebody, yeah, I went to Harvard. Wow, great. That sounds really interesting. I'm sure you had a good time with that. So I'm wondering, can we get back to the assignment that we're talking about the relapse prevention plan? And maybe you can, I don't know, you're running a relapse prevention plan group. Maybe you can start with identifying one of your triggers. So you just kind of accept the confabulation as it is, you don't challenge it, and you just move on, and you continue helping them with basic problem solving and life skills. All right, ADHD. ADHD is attention deficit hyperactivity disorder. It's characterized by an impairing pattern of inattentive or hyperactivity impulsivity. So impairing, meaning that a lot of people have inattention problems. Definitely people who are in substance use treatment, who are going through post-acute withdrawal, have a really hard time paying attention. But true adult ADHD, you're seeing an impairing pattern of inattention. The person keeps getting up and trying to leave group, in spite of the fact that you have a rule in group that you can't leave, once group has started. You've given them, let's see, a psychoeducational group, you've given them a document, everybody's reading a paragraph, and they put down their sheet and they pulled out the phone, even though they're not supposed to like look at their phone, in spite of the fact that you've told them numerous times. Like, it would be a real obvious inability to stay on task. So the inattention, the hyperactivity is being overly active, fidgeting, unable to stay seated, intruding into other people's activities, etc. So the big reason why ADHD is being mentioned is because people who have ADHD may have trouble with assignments that are typical in substance use treatment. You give them a relapse prevention plan to fill out their triggers and warning signs and bring it back to the next session, and they don't do it. And it's not that they didn't do it because they're refusing to do it. They're not doing it because they're showing signs of ADHD. And it would be very easy to see if it's true impairing ADHD. They're all over the place. They can't pay attention. They can't sit still. And so when you have somebody that has symptoms like this, again, this is a referral. Medications for ADHD are very good. And you may need to accommodate that in some ways by giving them more time on tasks, using multiple repetitions, checking comprehension, reducing distractions. Where I work, we often have counselors with clients who have ADHD using their individual counseling sessions in part to work on tasks and assignments that they would otherwise work on independently, so that they can help them stay on track. All right, we're getting close to the end here. So the dissociative disorders, the primary feature of the dissociative disorders is a disrupting of or a disconnection from the normal integration of consciousness, memory, identity, emotion, et cetera, et cetera. That's a clinical phrase. The bottom line is that when somebody is dissociating, they are disconnecting from their mind, from their body. It feels weird. They feel outside of what normal consciousness looks like. When it's a dissociative disorder, I mean, if somebody has, smoked marijuana or they've done, psilocybin mushrooms or something like that, that definitely is going to create a chemically induced dissociative disorder. Whereas somebody who has a true dissociative disorder, it is experienced as an intrusion. It's coming from the outside of me. I don't want this to be happening, and it's happening. I'm disconnecting from my body, and it's producing anxiety. I don't want to be disconnecting from my body. Now, dissociative disorders are frequently found in the aftermath of trauma. And you may remember that dissociation is one of the groups of criteria for PTSD, but it will often happen in all kinds of different traumatic experiences. So with dissociative disorders, you definitely want to make sure that you consider potential cultural influences. There are many people who come from cultures where dissociative states are normal. They're an acceptable expression of religious or cultural beliefs. There's encouragement to get out of one's body. You may have someone, who culturally, is coming in and they, tell you like, oh, I really believe in energy. And, I'm trying to think of, the old phrase would have been kind of a new agey approach. I'm not sure that that's the phrase that's used nowadays, but yeah, I leave my body sometimes. Like, I can sense other people's aura, I can connect in with other people. That's not a dissociative disorder. I mean, what you're seeing is more of a cultural reflection, of how the person sees themselves. Again, a true dissociative disorder is an intrusion. It's not something the person likes or wants, and it is creating some kind of anxiety. So dissociative amnesia is also an aspect of the dissociative disorders. Dissociative amnesia is an inability to recall important personal or autobiographical information that cannot be attributed to ordinary forgetfulness. Sometimes you're going to see this with the neurocognitive disorders. So it's going to be important to, again, refer to someone so that we can get testing done to figure out what's going on. But again, commonly associated with trauma, there are people that may have forgotten really significant parts of their life. They may have forgotten a particular family member. We worked with somebody once when I was at a facility where the person was homeless, didn't have their driver's license, and could not remember where they were born. And I mean, they had anxiety about it. It was very upsetting to them that they couldn't remember where they were born, but they could not remember where they were born. And it actually caused kind of a dilemma because in order to get a driver's license, we had to get a social security number. Social security numbers are issued from geographic locations, and the person had no idea what part of the country they were born in. And so it took a fair amount of work. So that would be an example of dissociative amnesia. Localized dissociative amnesia is failure to recall events during a limited time period. Again, we talked with trauma amnesia about an event that happened. A traumatic event would be a type of localized amnesia. Selective amnesia is the ability to recall some but not all events during a circumscribed time period. So somebody who grew up in a domestic violence household, you will often see examples of this where chunks of time have disappeared. And then global amnesia, which is pretty rare, you're probably not going to see this in substance use treatment, would be a complete loss of memory of one's life history. They have no idea who they are or where they came from. They just showed up there. Now, people who have dissociative amnesias, they're often unaware or only partially aware of those memory problems, again, associated with neurocognitive and trauma disorders, adverse childhood experiences. So if you see any evidence of this, this is another one that you're definitely going to want to get a referral. All right, so that was a lot, and that's not even everything. Certainly there's many other mental health conditions that I didn't even talk about that are in the DSM-5, but these are some of the ones that you're going to commonly see in substance use treatment, and then again, some of those severe persistent ones that you are definitely going to want to get somebody on board to engage with a referral. So we'll complete today's lecture with just a summary of the policy statement from SAMHSA, the Federal Substance Abuse and Mental Health Administration, about treating co-occurring clients in substance use treatment. So regarding screening, assessment, and referral, SAMHSA's statement was that all substance use treatment programs should have procedures for screening, assessing, and referring clients with co-occurring mental health disorders, meaning that if it's a substance use treatment program, you have got to have some kind of procedure in place to be looking for, assessing, and referring clients who have mental health conditions. SAMHSA also said that alcohol and drug counselors themselves must be able to identify clients with possible mental health disorders and ensure access to the treatment needed for each disorder. Now, our co-occurring disorders course in the Alcohol and Other Drug Studies program is this exact kind of training, and this particular lecture in identifying the major classifications is also related to this policy principle, that the alcohol and drug counselor needs to be able to identify when there's possible mental health symptoms, and ensuring access to treatment needed for each disorder is what I was talking about there at the end. So if you were identifying your client might have an adult intellectual disability, you need to connect that person with somebody, a supplemental referral to somebody that can help. If you have somebody who appears to have PTSD, same thing. So connecting them to treatment could include a referral and collaboration with a mental health clinician or psychiatrist on site. So somebody in the treatment program who has that kind of training. It could also refer to an outside mental health therapist. But note that in all these conditions, it's also going to include the drug and alcohol counselor using motivational interviewing and solution-focused counseling to assist with the treatment of those mental health symptoms. And the last policy statement here is that if the mental health disorder is beyond the capacity and resources of the agency, then a warm handoff referral should be made for a more suitable residential or mental health treatment facility or other community resource. What it means there in warm handoff is if somebody has complicated mental health symptoms and you don't have somebody on staff that can take care of that, you do not give them a piece of paper and recommend that they get their way across town and connect with a mental health facility. Warm handoff means that you have an ethical obligation to call a mental health facility, let them know that you have someone who needs more mental health assistance than you can provide, and you arrange for a handoff, which may mean you driving that person to that facility or them coming up to pick that person. That's the warm handoff, depicted by that kind of weird picture here in the slide of a little person being handed from one person to another, but you get the idea. All right, that takes us to the end of our lecture on identifying mental health symptoms and developing mental health awareness. As always, if you have any questions or comments about this lecture and you are watching it on YouTube, please take advantage of the comments section and I will be happy to dialogue with you. And if you are a student in the AODS program at San Diego City College, presumably you have my email and or see me in the classroom, in which case if you have follow-up questions, by all means come talk to me and I'll be happy to discuss. Thanks as always for listening.